Welcome to 2023 January CFP Distilled. My name is Dr. Simon Moore.
I'm Dr. Paul Dillon. We're here in Vancouver, BC after our sold out course in Las Vegas, ready to come across the country and continue teaching residents.
Exactly. So we got a review course this weekend. We do CCFP exam preparation, but here at CFP Distilled, we take a look at the clinically relevant articles in the CFP journal from this month. And let's take a look starting with the cover.
Yours is uncovered. I had this like super secret rifaximin. We had to tear away that farm advertising and then see, kind of a disappointing start.
Yeah, what is going on here?
I don't know. There's brain, there's vasculature, yet inside there's not a single relevant article about, looks like maybe it's MRIs. That's what they've done. They've sliced someone up like an apple.
Well, I think that does relate to the Parkinsonism and Parkinson's disease, which is the first article that we'll take a look at. So, diagnostic criteria, you need three things for Parkinson's disease.
Shaky, stiff, and
slow. Slow, shaky, stiff, because I can never remember those big words like tremor and bradykinesia and rigidity. But there's a key point we talk about when we review this at the review course. It's not Parkinson's disease. That's not the 105 topic that you're studying for the exam. It is Parkinsonism. Yeah, so that's why we've got to consider all the other possible causes. And this part one on Parkinsonism really goes into detail about how do we distinguish these. So some other possible causes. We've got a great table here on table one. They talk about, could it be a vascular cause? Could it be multiple system atrophy? And how do you tell those apart? And then we also got progressive supranuclear palsy. If you've got something like, truncal rigidity, or if you've got extraocular movement changes, then these are ways you can help distinguish, is it Parkinsonism from one of those other diagnoses, maybe from their medications, or perhaps it's from Parkinson's disease.
Let's stick with the elderly and talk about chronic kidney disease in the elderly. What can we do? What are we watching for in these patients? Because they're going to be managed by us in family practice. So a really good, quick article that talks about the KIFRI score.
KIFRI score is amazing. It's a calculator. You punch in their score and it tells you what is this person's chance of having kidney disease in the next 5 years.
So it's basically like a Framingham risk score for your little kidneys there. Key numbers to remember is 5% over the next 5 years. So if your KIFRI score comes back with 5 over the next 5 years, you're going to refer them and watch them a little more closely.
Something else to watch closely is you got to do a really close exam if somebody's complaining about anal fissure. You got to get right in there, a lot of stretching involved to move those skin folds out of the way. So if you see that midline fissure, remember if it's not midline, you're thinking something else like Crohn's. But if you see that midline fissure, there are 3 pharmacologic options you need to be aware of. So the first one, the most highly recommended, calcium channel blockers.
What about nitro?
Nitroglycerin. Another option, but there's a huge side effect. Almost half of people, actually over half of people, 56% are going to get headache. And now there's a third option. This was new to me when I read this article.
Put my hands up, same. Vitamin E, I did not know of this option.
So it's interesting because the number needed to treat for calcium channel blockers is 3, nitro is 4, vitamin E is 5. So what do we do though if the topical treatments fail?
Well, you can use Botox for those bottoms.
Yeah, and the other option to think about always is surgery. Both of those are going to run you the risk of fecal incontinence, not something that you want to be responsible for your patient.
No, you'd want to run from that. Common oncologic emergencies. This is a great article that talks about 3 things that you need to be thinking about or have a high index of suspicion for. Number 1 is going to be spinal cord compression.
Yeah. Another one that you're going to look at is if they've got, it talks about all sorts of things. It talks about hypercalcemia. It talks about febrile neutropenia. So let's talk a bit about the febrile neutropenia.
So for febrile neutropenia, you got a high index of suspicion for these patients who are immunosuppressed. You're going to be looking for the absolute neutrophil count, and you're going to want to be getting antibiotics tailored to them on board right away. The last one, what if I've got spinal, like
superior Vena,
Cava
Constriction. Yeah, so these folks, they come in looking like that. Their jugulars are distended. They've got edematous face, and you're starting to think about, could there be a mass in that mediastinum? So phenomenal article, talks about how do you investigate these things, when to suspect them. Make sure you look at the SAMP questions on this that we're going to be sending out in 2024.
Wow, looking forward to another amazing year. For those of you that are interested, we do have a Facebook group where you can ask questions to people who have recently written the exam, for people who will be writing the exam soon. So join that Facebook group if you're interested. We'll put the link up on the screen.
So I'm very excited. We're about to go downstairs and start teaching at the review course in family medicine, Vancouver 2023. It's not too late to sign up for Calgary or Toronto, or maybe we'll see you in summer 2023 in Toronto. Hope to see you there. I'm Dr. Simon Moore.
And I'm Dr. Paul Dillon.